and finish off that sentence, then come back.
Okay.
Maybe. But
So we
you
can
people
have,
continue. You people
yeah,
continue.
we can have your opinion, views later on also. But opening
Yeah.
remarks you can make, sir.
Yes,
Okay.
definitely.
Okay. Thank you, sir. Sabyasachi and yeah,
We are live.
welcome. Good evening.
We are live?
Hello, sir. Good evening, sir.
Well, yeah. Are we live, Mr.?
Yes, sir, we are live.
Okay. So friends, esteemed members of All India Ophthalmological Society and all our friends and members from also Maharashtra Ophthalmological Society. We all know that pilocarpine was first isolated back in 1874 by Hardy and Gerald. And from that time, it was used for over a century as a part of glaucoma management. Of course, there were better molecules which came into vogue with better safety, better efficacy and predictability. And that's the reason the pilocarpine usage diminished a lot around the world. But about 3 to 4 years back, it made a resurgence because of the fancy of pilocarpine providing a better uncorrected reading vision for our presbyopic population. We all know that presbyopia is possibly the most common refractive error in the world today. And of course, those people are always looking for solution, especially if they are non-invasive, customizable, and possibly reversible. So there were studies done in the US which showcased the efficacy of this new drug as a resurgent treatment for presbyopia, but there were concerns which were raised because of a variety of case reports. And today's spatial webinar is the first of its kind webinar in Indian ophthalmology, which is about use of 1.25% pilocarpine for presbyopia to go into the depths of this evidence-based matter and discussion. So me, Dr. Vardhaman Kankriya, as the member of Scientific Committee of AIOS and also the chairman of Scientific Committee of MOS, would like to welcome you. Now we would like to invite our mentor, I think teacher's teacher and our inspiration, Dr. Lalit Verma, sir. Sir has been an inspiring figure, especially for me, for more than 15 years. And from the time I saw sir for the first time when he came for Goa MOSCON in 2015 to today, when sir introduced the Best State Society Awards for last 2 years, and MOS has been especially happy to receive this at the national level. So that is thanks to you, sir. So now I would like to invite Dr. Lalit Verma, sir, to please say a few words before we go further.
We must congratulate MOS as well as the chairperson of AIOS, Namrata Sharma, for taking this lead because, exactly 1 week ago, in the early morning, I was, reading Times of India. This news came with a blast. In fact, it was not a usual, like Vardhaman said, Pilo is not a new drug. Pilo is age old, and US FDA had approved this long time back. But the way it made a blast in the front page created a furor actually. And a lot of people, a lot of ophthalmologists, a lot of patients started asking. And exactly a week afterwards, that is yesterday and today, we read this news again that this has been withdrawn. So I think the company has now said that they will maybe challenge in the court also. But we will not, as clinicians, as scientists, as ophthalmologists, let's not go into all those things which controversial aspects, what they are debating about ethics and representation and CDSCO and DCJ and other things. But what we should be doing, the purpose of this webinar, and I am very happy that MOSCON and scientific person have taken lead. You see, our aim here is not to formulate guidelines for anybody. Our aim is to discuss and debate that what has suddenly come out, which was not known before. What is the role of glasses today? Can we use it safely, or there are alternates available? And how should we be using it? And let the not claim go that this is the first drug available and some miracle has been done. That is not true. There's no miracle here. And the reason of, I think Vardhaman and Santosh taking up this issue immediately is that many ophthalmologists, have meetings with they're issuing, some kind of cautionary alarms. And reason that, presbyopic glasses will be thrown away, that is not true. And I think after we listen to the talk of Sabyasachi, we will talk about this scientific parts only. and we'll not go into other aspects. And our aim of this webinar should not be, Namrata, to frame any kind of guidelines. Our aim should be that what is the science behind all these things, and why did this happen, and why, and what as a scientist we should be doing. And maybe this is a preamble, or maybe this is a beginning of from the ophthalmic point of view. And I'm very happy, Vardhaman, that you people have taken a lead,
Thank you,
and led by none else than Namrata Sharma, who never even I remember, Namrata, when TAS epidemic had occurred, and I was a president at that time, and we immediately sat down, because it is the duty of AIOS, it's the duty of the largest body of ophthalmologists in India to be concerned when something unusual or something alarming happens, that AIOS should sit down. And I'm also happy that Dr. Basak and Santosh Honawar, they have instituted a 12-member committee which will go into the nitty-gritties of everything and maybe come out with guidelines after some time. So thank you, Vardhaman, for having me here. Thank you, Namrata, for having me here.
Thank you, sir. It is an honor for us, sir. Thank you so much for sparing your valuable time and giving your insights. So now I would like to invite our Scientific Committee of All India Ophthalmic Society's chairperson, Dr. Namrata Sharma, ma'am, to please say a few words.
So thank you, Vardhaman, for taking the lead and for organizing this Pilocarpine eye drops for presbyopia. Innovations come and innovations go, but some of them, they stay, and it is important to know which are actually going to stay. For presbyopia, pilocarpine has not only been used today, but has been used for quite some time, much earlier also, was discontinued in between and has come back again. FDA has already approved this drug, and it is already available in US. I think it is important for any innovation or any product which comes to know when to use it, and of course, very important when not to use it. So that is something which is going to be discussed threadbare. And after the talk, which is going to be given by Dr. Sabyasachi Sengupta, who's going to go through the entire literature and tell us where pilocarpine stands today. I'm sure the other experts would also help it to dissect it further. So I think, Vardhaman, we can begin with the webinar now and take the deliberations further.
Thank you so much, ma'am. Thanks for being the guiding force for all of us, as always. Now, before going further, I would like to now invite our guide and support, very dynamic president of Maharashtra Ophthalmological Society, who has had a tremendous historic tenure, I will say, as a very successful president with a lot of new innovations and a great support for everybody. So I would like to now invite Dr. Santosh Agarwal, sir, please to say a few words.
Thank you, Dr. Vardhaman. Respected Dr. Lalit Verma, sir, Dr. Namrata, ma'am, all seniors, distinguished experts, panelists, and my dear friends. Very good evening to everyone. I welcome you all to this very important meeting of today, that is Pilocarpine 1.25% eye drop for presbyopia. As you know, Pilocarpine 1.25% was introduced in the market, and we are skeptical about its indiscriminate use, over-the-counter use, and it can cause side effects if used for a long time. So our motto is science should prevail. The safety and the best possible treatment to our esteemed patients should be assured. This can be achieved by evidence-based medicine or preferred practice pattern. Many rumors are going viral on social media and everybody is very confused. Today's webinar would certainly shed light on the very evident facts about the medicine and enlighten our colleagues about when to use it, what are the indications, what are the contraindications, what are the probable side effects, what are the long-term effects, etc. Also, now it's our duty as a society to make the public, chemists, and pharma company and government aware of its side effects, and we have to send the clear message to all stakeholders that it should not be used indiscriminately and over the counter. Rather, it should only be under the supervision of ophthalmologists, and it should be given after the prescription of ophthalmologist only. I sincerely request all panelists to please restrict our discussion to scientific facts only. MOS is always on the forefront to organize such discussions. I am indebted to Dr. Namrata ma'am, Chairman Scientific Committee AIOS, Dr. Lalit Verma sir, and all panelists, and of course my MOS team, especially Dr. Vardhaman, Aditi, Atul, and Mandar for taking untiring efforts for this webinar to happen today. I am looking forward to a great discussion today. Thank you very much, everybody, for making this possible. Thank you for your patient listening. Over to Vardhaman, please.
Thank you very much, sir. Thank you for your insights. Before we go to the talk, I would like to now very quickly give introduction of our expert panelists. We are very lucky to have people who have dwelled into the science of this drug at depth. And to begin with, I'm happy to have Dr. Muralidhar Ramappa, who has been a clinician scientist and a world-renowned pediatric cornea specialist at LV Prasad Eye Institute. He heads the Special Institute of Rare Eye Diseases, has been trained in the US for pediatric corneal work, and has had more than 120 international publications. A researcher at heart is going to share his insights. We are also honored to have Dr. and Professor Rohit Saxena, who is the professor of ophthalmology at the RP Center at AIMS, and who has been also one of the committee members, which is newly formed by AIOS as an expert committee to go into the depths of the pilocarpine issue. We are also very lucky to have Dr. Manoj Sasavade, sir, who is a retina consultant from Aurangabad. He's an alumnus of prestigious Shankar Nethralaya, has a tremendous and a very large-scale experience over decades, and sir's insights will be very valuable from the retina point of view. And we are very, very honored to have Dr. Rajul Parekh, sir, who has been an alumnus of CMC Vellore, trained under the legendary Professor Ravi Thomas, sir, and then was a LVPI consultant before he moved to Mumbai to do decades of service in glaucoma. He's currently the educational committee member of World Glaucoma Society. So we have these experts who are going to enlighten us in the panel discussion. And now, before we go to that, I would like to now invite a very dear friend, Dr. Sabyasachi Sengupta, who is a researcher, a retina specialist at the Sengupta Research Academy, and also the Future Vision Eye Hospital in Mumbai. Sabyasachi has been trained primarily in Shankar Nethralaya. In his Retina, has done a very prestigious research fellowship at the Wilmer Eye Institute, has been at the forefront of evidence-based medicine, has published more than 120 international papers, has been on the editorial board as the assistant editor of the Indian Journal of Ophthalmology for 2 terms. And most importantly, for today's webinar, he is going to threadbarely dissect the current evidence that we have so far about this drug, which is pilocarpine 1.25%, as the solution for our presbyopia management. So I would like to now invite Dr. Sabyasachi to please deliberate on this with his talk. Thank you. Over to you.
Thank you so much, Vardhaman, and thank you so much, Namrata ma'am, and everyone else at MOS and AIOS for, giving me this mantle, I should say, to, sort of dissect some of what we are going to discuss today. Let me quickly share my screen. All right. I'm going to start with a quick drum roll so that whoever is dozing a bit should be up and running.
I think there's no sound.
Right. So we are discussing pilocarpine and presbyopia. Enough of that. Right. So, what we're really going to try and understand are some of the clinical trials that are, just a second, yeah. We're going to try and understand some of the clinical trials that have been done on pilocarpine, specifically for the use of presbyopia. As has already been reiterated before, that pilocarpine has been around for decades, like 50 years, right? So pretty much the oldest anti-glaucoma medication that is known to us. And, it had gone a bit quiescent, like many diseases, but now it has come back with a roar, and, we are looking to use it for management of presbyopia. And so let's understand how these clinical trials have worked, and then we can deliberate whether we should adopt it or not. And, hopefully we'll get a good idea of where we are and where we are going. And so the idea also is to, sort of teach you how to fish and not to fish for you. So sort of, how to interpret clinical trials in general, not only for this, but, on a larger scale. So because, we're going to come across trials all our lives, right? So hopefully I'll be able to, sort of transfer some of these templates which you can use to interpret clinical trials as well. So let's understand that, wearing glasses is a bit of an issue. If we know that, beauty lies in the eyes of the beholder, so, someone who is, very, sort of glamorous and wants to be in the forefront is never happy to wear glasses or hide behind glasses. As you can see, this film star on the extreme right is in glasses, and, so the image just says it all. And, first thing and foremost thing is that, we need to realize as physicians that the problem is real, right, for a patient. And, so we need to do something about this. And I'm really happy that, we are already underway and that there is something already coming up, and we'll see where we are and where we're going. So, as Vardhaman has already introduced me, so I'm predominantly a vitreoretinal surgeon practicing in Mumbai. And quickly, I would like to sort of just remind you all that try and keep your microphones on mute. Some of my financial disclosures, though nothing is relevant to today's talk on pilocarpine. A quick disclaimer is that all the interpretations and thoughts that I'm going to sort of talk about today are mine alone, and neither has AIOS nor has MOS nor has NTOD or anyone else actually interfered in any of the things that I'm going to speak. So hopefully I'm going to make sense to all of you in general, coming from a clinical trials point of view. So what is presbyopia? Quickly, so let's try and understand what is this presbyopia, and so that we actually fathom what pilocarpine is doing internally, and also that some of us watching might not be from the medical fraternity, and maybe from the general public, and so let's quickly understand what is presbyopia. So the eye is really like a lens, and it focuses, and like any other lens, it also has an aperture in the center, which is called the pupil. So this is the lens aperture of a camera. So the pupil in the eye does the same job, where the pupil actually dilates or enlarges if there is very dim light, and it constricts or contracts when there is a lot of bright light. So it basically is a regulator of how much light goes into the eye. And in a real human eye, this is what you can see, the pupil is actually going small, and this is in response to something which is coming close to you, not in response to light alone, right? So the pupil is one factor in seeing near vision. So near vision really is not just about the pupil, and we call this accommodation, and it's about the pupil as well as the ciliary body. So what is the ciliary body? I'll quickly show you a video which I borrowed actually from YouTube, and I've given some attributions to it. Let's understand what is accommodation, how it happens, and then understand how pilocarpine works.
The engine of accommodation is the contraction of the ciliary body mediated by the distribution of forces via all elements of the zonular apparatus. The resultant changes in refraction are due to the increased thickness of the lens and the increased curvature.
Dr. Sachi, there is no sound. Can you just pause for a minute?
No,
All right, so
Sound is there.
yes, I'll just go to the next slide. I'll just talk
No.
about it. So this is really how it acts.
It is there. The sound is there, Sabyasachi.
Okay, so I'll just play it again.
It should be little louder.
Distribution of forces via all
If you
elements of the zonular apparatus. The resultant changes in refraction are due to the increased thickness of the lens and the increased curvature of the anterior and posterior capsule. The complex anatomy of the vitreous zonule results in traction on the vitreous membrane peripherally and traction on Weigert's ligament connecting the posterior capsule and vitreous membrane.
So I'll perhaps go to the next slide so that some of you who might not be able to hear. This is really exactly how accommodation happens. This is contraction of the ciliary body. The posterior zonules are contracting and there is traction on the peripheral retina, while the anterior, I'll just quickly play it again. So, this anterior zonules are going to relax, and that's what is going to cause the lens to bulk up, and the posterior zonules are going to contract. And when there is ciliary body relaxation, the anterior zonules contract and the posterior zonule relax. So you can clearly see that there is some amount of traction which is happening on the periphery, as well as, all of this is, so essentially what pilocarpine is doing is leading to pupillary constriction. It is also leading to ciliary body contraction, tautening the posterior zonules. which is causing some amount of traction in the retinal periphery and is leading to relaxation of the anterior zonules. And all of this together is leading to swelling of the lens or increase in the anterior posterior diameter of the lens, right? So as we know with aging, this this increment in the anterior posterior diameter of the lens suffers. And that's why most of us start getting presbyopia by the age of 40, because the lens becomes less and less elastic with age. So interestingly, this was a very old paper on pilocarpine, and what it has done is looked at 4 concentrations of pilocarpine in normal subjects, and it actually says that normal pupils constrict to dilute concentrations of pilocarpine, including 0.25%. Remember, today we are talking about 1.25%, but then normal pupils constrict with even 0.25%. Even half of that, and even half of that, and even really half of that, right? So then why do we need 1.25%? So I'll show you some trials which have actually used 0.4% and have been relatively successful. But just that, these lower concentrations may cause pupillary constriction, but may not cause enough ciliary contraction, right? So accommodation actually may not be happening, right? So therefore we need slightly stronger concentrations. So with this in mind, let's remember also that if it's a rigid pupil, that pupil is not at all reacting to light, it's already small right from the beginning, chances of all those mechanisms happening internally are not that high, because the pilocarpine, it's already small enough, and most of these patients may not even ask for presbyopic corrections. So, like I said, let's jump into some of the clinical trials that have been published so far. Some basics are, most of these clinical trials use Snellen's acuity for for their presentation of results, while we use mostly Roman or Jaeger acuity. So 2040 in US Snellen's is N6 for ours, or J5, and in 2030 is N5 or J3. And as the number increases, the visual acuity gets worse and worse. So 20/60 is N10. And most patients in these trials are perhaps at this level, at about N10 uncorrected, right? So just a quick basic before we go into, dive into the results. So these are the 4 trials that we are going to discuss today, and, using a same template, and then, we can actually, in the end, compare across all of them. So the first one is, of course, the Gemini phase 1 clinical trial, which has been published in 2021, and then, the drug has received, US FDA approval and has been used for the past 3 years in the US, has been marketed as well. And the other is the Virgo phase 3 trial. We'll talk about these. The other is near phase 3 randomized control trial, which has been recently published, as you can see, 2024. And then some of our own data from trials which are conducted in India. So, so hopefully, I'll be able to give you a template. So template to apply clinical trials, and then interpret all these published results together, and then hopefully derive some guidelines across. When we look at all these trials together on one screen, we'll be able to tell, what works, what doesn't work, and how much it works, and then some take-home messages. So 5 steps to evidence-based medicine or to apply trials, is to look at the inclusion-exclusion criteria of the trial and see if your patient would actually be part of that study. It will be relatively broad. Then look at how similar your patient is to that patient in a clinical trial. So what does an ideal clinical trial patient look like, and how much variability does your patient have with that ideal patient? So is your patient really an ideal patient as part of the trial? And then you look at all the interventions which are present in that study. So in this case, there are only 2, right? It's either pilocarpine or it's not. It's either a vehicle or something else, or placebo. And then you look at your results and see, if you treat like the study said, your outcome should be like the study, more or less, give or take. And if you find a lot of differences, you should think about publishing your own data that, these guidelines have been given and I'm following these trial protocols, but it's not working, right? So let's look at the Gemini phase 1 trial, which is, the phase 3 trial, that's Gemini 1. And, so the drug actually was called AGN 190584. That's and the trade name is Wheaty, and it's 1.25% pilocarpine and manufactured by Allergan, which is now an AbbVie company. So this is overall some of the outline of how the trial was done. So 323 patients were enrolled, a relatively good number. 163 got the drug and 163 got the vehicle. It's not really placebo, it's a vehicle, and it's a proprietary vehicle. We don't know what contains, what are the contents of that vehicle. And I'll give you some perspective on what I think might be there. And it's not just distilled water. And then about 161 and 153 completed 30-day follow-up. That was the time when all the results have been computed and published. So this is the template that we talked about. So what were the inclusion exclusion criteria of this trial? So this were patients between 40 and 55 years of age. Of course, they are in the presbyopic age group. Yeah, so they were in relatively good health, and they had confirmed presbyopia. That that as a definition, that is using the NEI-VFQ questionnaire, where at least one question between question 5 and 7 had a particular score, right? So this is all confirmed. It's like may or may not be. It's not like that. So in all of them actually had confirmed presbyopia, and they were between -4 and +2 diopters for distance correction. So anyone who was little highly myopic or -5, -6 were actually excluded, and we need to remember that. And that best corrected vision, distance vision was 6/9, and mesopic near vision. Mesopic means looking at vision in dim light was supposed to at least be N14, right? Or between N5 and N14. And photopic near vision, which we really check in our clinics, which are well lit, all of them should have at least N6 or even better, right? So this is pretty much what we would also look at when we are doing our patients. Now, how was an ideal trial patient in this? So most were 50-year-olds, otherwise healthy. Most were white, and more than 70% were women in this trial. So we are looking at a 50-year-old, otherwise healthy white lady who is mostly emmetropic, because most of the study patients are emmetropic, and had a baseline uncorrected, or that is distance corrected near visual acuity. That is, you're wearing your distance glasses if you have any, and they were either between N10 and N12, somewhere in that range. So this is an ideal patient. If you think about your patients who are coming to you, instead of the white, if you make it Indian, and the lady or gentleman perhaps doesn't matter, right? So this is pretty much what an ideal patient would look like in a trial, and then you need to match it with your ideal patient. So if somebody who is 42-year-old comes and who has a vision of N8, we don't expect trial results similar to this. Similarly, if somebody is 57 and has a uncorrected vision of N24, we perhaps don't expect so much improvement, or the improvement that happened. And of course, we know there are two interventions. One is the Pilocarpine arm, which is the VUIT, and the other is the proprietary vehicle, which we don't know what is there in that, but it's not Pilocarpine. And then we'll look at trial, outcomes. So, let's quickly see that. So this is a, sort of screenshot from the actual study. You see the mean age is about 49, like I said, about 50. And if you see females is about 72.8 or 73%. So, a lot more women than men. And then if you see they are whites, about 90% are whites, right? So what I've tried and done is crystallize all of this into an ideal patient. And then I have presented that to you. And then they have talked about what were their baseline visions, etc. Now let's look at the results. Before we go to the results, I want to quickly tell you about the outcome measures. So if you look at this slide, the background is a little bit, the contrast between the foreground and the background isn't that great. What if I make it like this, where the outcome, the background is white and the text is a little grayish, and you're finding it hard to see, especially if you're on a mobile phone. So this is low contrast near vision. So the font size I have used throughout from now on is actually N6 font size, just to match it, and for you to actually, sort of have an experience, especially if you're sitting about 40 centimeters from the computer screen or from your mobile phone, right? So this is not really ideal. So, this, if you actually test this, then, you're going to get a lot of failure rates. What if I do this, where, this is high contrast now? So what the trial actually used is high contrast near vision tests. So, and the room light may be dim or bright, but the near vision charts that were used were something like this. So what if I make the background again like this? And now what if I make the background like this, right? So this is essentially what there will be differences in your, room illumination, and that will influence results. What if I make the screen totally dim like this? This is about 10 lux, and this is about N6 size. Though it's a high, it's a high contrast background. This is what was actually tested as a primary outcome, which was, put forward by the FDA. So it's a really high it's a high, if you take off if those who are emmetropic and not wearing reading glasses, if you take off your glasses, you will realize that, oh, this is very hard to read, especially, that I have dimmed the light, and this is bright light. So this is about 250 lux, right? So the primary outcome is 3-line improvement, or from most people, it was N10 to N5 in dim light. Right. So we know the ideal patient is 50-year-old lady who is white, has a baseline uncorrected vision of N10, is mostly emmetropic and has a mixed or brown or light colored iris. And so how many actually got to this time point? At 1 hour, only about 40% saw this. Right. So that's relatively it's not that great. It's only about a third of patients compared to about 15% in the vehicle. So that's also quite high, right? So something is in the vehicle which is causing people to see, somehow a little better. So the difference is about 25%. At 3 hours, the effect is starting to wane slowly. That's only 31%. So really at 3 hours, only about 1/3 of the patients will see, right? So 2/3 are going to be unhappy, right? So then we are going to get phone calls and saying, oh, it doesn't work, it doesn't work. But remember, the bar is set really high, right? And then at about 6 hours, it's almost gone. And then they'll have to re-put it again. What if we drop the bar and say, instead of 3 lines, if we say 2 lines, N10 to N6. So from N10 to N8, N8 to N6. So only 2-line improvement, but in dim light. Now that is all right. I think from a clinical point of view, even 2-line improvement is pretty good. Now what happens there? So this is a graph showing that 40% improved at 1 month, at 1 hour, and that drops gradually as time goes. If you drop that bar and say only 2-line improvement, that is getting to N6, which is pretty good. That number jumps. At 1 hour, about 68-70% are seeing well. At 3 hours, still 55% are seeing well, compared to about 30%. So these placebo numbers or the vehicle numbers are also relatively high. But still, let's concentrate on the pilocarpine numbers. At 6 hours, still about 40% are seeing well, right? So, for outcomes which are clinically more relevant to us, 80% will see well at 1 hour, right? And they'll pretty much be able to do all their activities. At 3 hours, still 60% are seeing well. So, if we counsel them in this manner that, okay, this is what you are expected to see, there's very little chance that they're going to call us and say, oh, I'm not seeing well, right? And because we know what to expect, at 6 hours still, it's little lower than 50%. So it's starting to wane, and this is the time point when perhaps repeat treatment might be necessary. Okay, now we have only looked at dim light, but then a lot of our patients, and including us, ourselves, work always in brightly lit rooms. And if you visit a typical American home, they are all very dimly lit. But you visit typical Indian home, it's very brightly lit. So what happens in bright light and how many actually get to N5? That number is very high. It's 92%. So almost everybody who takes pilocarpine, right? So at 1 hour, almost everyone is going to see well, especially if they're in bright light. At 3 hours, it's slowly starting to wane. At 6 hours, it's still high. Right? So if you tell people that you can, if you want to use it, you need to be in relatively bright conditions, and then, you need to have good contrast between what you're seeing and the background, it might actually work pretty well, right? So this is overall, the results from the Gemini study in terms of how much improvement there is. Remember, the primary outcome bar is set very high, but from clinical point of view, this is something that, we might actually talk to our patients, and maybe even this is something that we could convey to them. The pupil size, of course, constricts, and that's sort of proof of concept that the drug is really working, right? So this is comparison between mesopic and photopic pupils, right? So if you see the baseline pupils are almost more than 4 millimeters. So we know that, the Caucasian eyes or the white eyes, like predominantly white people, have very large pupils, so non-mydriatic imaging works very well in them for fundus imaging. Whereas, dilated imaging is required for Indians. We typically have baseline pupil sizes of less than 3 millimeters or anywhere about 3.2 millimeter, right? So, even mesopic. So photopic pupils are going to be even smaller. So, but overall, this is where the pupil size mattered. So, this is where we are. So when patients are in bright light, they actually seem to be doing well. If they're in dim light and they are expecting only N6, which is also pretty good, they will probably do well as well. At 1 hour, 100% patients said they're satisfied. And at 3 hours, about 70% patients said they are still satisfied. Right? So this is really coming from these results, or perhaps even these results, and not from the primary outcome. Right? Then adverse effects, about 14% had headaches. Most of them were mild. And 7 to 8% had blurred vision for distance. We know that, constricting the pupil a lot will cause a little bit of blurring of vision. Sometimes it can even improve vision with the pinhole effect. And, that did not happen in this study. But overall, this is the results from the Gemini study. Let's look at the Virgo study. So this is twice daily dosing of 1.25% pilocarpine, right? So you give, and then, as we've seen, the effect wanes at about 4 to 6 hours. So they have given another drop at 6 hours time point. And let's see what happens. So this is overall, pilocarpine had 114 patients, and the vehicle, this is the same drug, the same vehicle had 116 patients. And now let's look at the Virgo. Again, very similar patients, 50-year-old white woman. Women were a little bit more than men. I haven't put women because, the numbers are about 60%, not 70%. But, you can imagine that almost similar looking patients in the two groups. Now, how many actually got to this 3-line improvement? So this is the baseline characteristics from the same study. So it's about 50 years, and see women at about 60%, right? So this is how the baseline characteristics look like. At 1 hour, again the results are similar: 35% versus 8%. So about a third are seeing well when you set the bar high in terms of illumination. When you set the bar a little lower, again 60%. So about 2/3 are seeing well, but they don't give us results from other time points. Interestingly, they don't give us anything about what happens in really bright light or photopic conditions. But at 3 hours, they actually say that it is 33%. That's like really low. So why would somebody see something going wrong, and I couldn't really find out why. So though they don't concentrate on these results, they primarily concentrate on some of these results. And what they have additionally provided us is something like this, where so this is 2-line improvement, right? So we are setting the bar a little low. So this is the 30% improvement line that I have drawn actually. So what they are really telling us is that it's most efficacious in 50-year-old women who are predominantly part of the study, with vision of N10 to N12, who is okay with if effect lasting for 4 to 6 hours, and who does not mind reinstilling eye drops. And when started, about 2/3, but not all, will get to N6, right? So if you see baseline, this vision, if it's worse, so 2063, that's about a little worse than N10. They had even more than 30% gain. More than 30% actually saw better, right? While the vision is already better at baseline, so N8 or N10, and they did not have that much benefit. Obviously, the vision is already good at baseline, right? So it is good for somebody who is nearing 50, and baseline vision is uncorrected vision is N10 to N12, and we need to tell them that 2/3 will improve. So you may or may not improve, right? But then you may improve if you're targeting N6. But if you're targeting N5, again, only about a third will improve. So this is the Virgo trial, and the adverse effects actually had some distance vision improvement, like we know it can happen. So this is, graph from the study. So, on the x-axis, you will see this is distance vision, CDVS, corrected distance vision acuity. So anything on the right of this or of this vertical line is improvement, and these, circles which are colorless are actually pilocarpine here. So a lot of patients are on this side, on the right side, or on the correct side. So a lot of patients actually had improvement in even distance vision, as we know can happen. And a lot of this is dependent on many factors, including, how clear the lens is. The next study we'll look at is the NEAR study, which is the phase 3 randomized trial. What it really did is used 0.4%, not 1.25%, but 0.4%. And it uses it twice a day, that is 2 hours post dose 1. You give it immediately. So you give it at 8 o'clock and then immediately give it at 10 o'clock. Remember, this is a very low concentration. And I showed you some studies in the beginning, which actually use even 0.25%, right? So, so what happens if you actually drop concentrations? Remember that perhaps becomes a little bit safer because the traction is a little bit less on the peripheral retina. So, how did these patients look like? These are little older patients, 54-year-old. Again, mostly were women, and almost everything else remains the same. At 1 hour, again, about 40% had improvement. At 2 hours, this is the time point when the second dose was given, right? So here at 3 hours or 1 hour after the second dose, 50% actually had better. Again, this bar is set very high, right? So, and at, so overall, if you see these graphs, at 1 hour, about 40% had improvement. At 2 hours, that drops slightly, but then you give the second drop, then again it gets better, right? So it goes to 50%, right? So the takeoff is a little slower. That's because it's slightly, weaker drug, but then you need to repeat it. So is it worth repeating a drug immediately 2 hours later? Our patient is going to be okay with repeating a drug 2 hours and then maybe again at the 6th or 7th hour or something like that. So it's going to be not twice, but maybe thrice in a day. And that's something that we can debate about. But then if it's safe, we might go for it. But then, overall long-term data are not available. When you look at, when you drop the bar, again, it's about a third of the patients are benefiting, and they don't report anything about what happens in photopic conditions or bright light. And, so this is what they reported about, so as you can see, these are all the rates. This is at day 15, basically. So overall, at 3 hours, at 4 hours, also it's high, 70%, 71%, and then it gradually drops off, right? So it's relatively sustained. That's because you're giving 2 drugs back to back. This is the effect on the pupil size, pretty similar. This is at day 15 again, pupils, you see the pupil is coming back, and at that 3rd hour time point, you're giving another drop, and again, the pupil drops. And compared to the, previous Gemini trials, very similar results are seen. And overall side effects, not much. 7% had headache and nothing much to report about. So overall, all are very in sync with each other. Let's see, a study which was, this is screenshots just showing you that about 7% had headache. So far, most efficacious in about 50-year-old ladies, give or take, with a vision of uncorrected vision of N10 to N12, with effect lasting for about 4 to 6 hours, and doesn't mind reinstilling eye drops, right? And so this is, I'm just repeating it again. And 2/3 will have improvement if you're looking at N6, even in dim light. 1/3 will have improvement to N5, even at 4 to 6 hours. And there are slightly weaker drops, 0.4 drops, which may also be effective, needs to be instilled more frequently. Peak effect occurring at about 3 to 4 hours, not sustaining quickly, and not dropping off quickly because you're reinstilling again and again. So this is unpublished data from clinical trials which has been conducted at home by Todd, who is making drops and trying to make it in India. And I think we should all put our hands together and sort of congratulate them, because clinical trials don't happen very frequently, and a lot of pharma companies are perhaps not even looking at conducting clinical trials. So then, so I think it's a good job done. Let's see what the trial said. So how did the ideal patient in this trial look like compared to all the other patients? These were predominantly 50-year-old, but men were more common. More than 60% were men, and then rest are all similar. Of course, the iris was brown. So this is how an ideal patient would look like. Very, overall, the BMI is almost 25. So a lean 50-year-old individual who's quite fit. And, this is how, this is just a representation. This is how an American clinical trial patient might look like. And this is really how an Indian trial might look like. Other than gender, and pretty much all else is similar. Now, what happens to the primary endpoint? Again, about a third, if you set the bar very high, about a third are doing well, and then it's slowly waning off. What happens if you drop the bar a little bit? Say 2-line improvement. So this is just a graph showing the same thing. What happens if you look at 2-line improvement? Alas, that data is not there. At least in the trials and the material that I have obtained from the company, I could not find what happens if you just drop the bar. And I think this is really important for making decisions, because this is the one which is like the really clinical relevant, and we're looking at N6, right? And I think it's pretty good enough for most ophthalmologists. When you look at what happens in very bright light, this is more realistic, where 65% patients are seeing well compared to 90% in the Gemini. That's like way too high. And like I said, this vehicle is doing something and bumping up these numbers is what I feel. But then, we don't exactly know. So, 65% are seeing very well at 1 hour, and that maintains at 3 hours. And then we don't know what happens. But still, 2/3 are going to see well if they are in bright light, which is the case in most offices and, most homes in India. So then, if you're just looking at this, the drugs works pretty well. In one of the figures, they show this number to 76%, and this is not a reviewed manuscript, and perhaps there are some discrepancies, but it's very minor. And the side effects are again quite well tolerated. It's about 11% headaches at all mostly mild, and not much elsewhere. So when you compare across trials with a bar set very high, which is not even realistic from a clinical point of view, but then the FDA mandated that. So, it has been done and it has been reported. It's about a third of the patients, about 35 or so, will do well at 3 hours. But then if you drop the bar a bit, that number doubles. So about 2/3 will do well at about 1 to even 3 hours. Right. So overall, in the Virgo showed little higher numbers, and the next the near study showed even higher numbers, right? So unfortunately, the Indian study doesn't have those numbers, but overall it's about 2/3, right? So I think that's overall quite acceptable, and that adverse effect profile is quite tolerable. So far it is most efficacious in 50-year-old lady, with vision of N10 to N12 at 40 centimeters. So let's understand 40 centimeters is quite close, and not at an arm's length. It's almost half an arm's length when we are measuring. And so most patients tend to sort of push it away, and then we allow them and say, it's okay, you read how you can. But then from real application of trials, we need to actually enforce and tell them, no, you need to read as close as possible. Then who is okay to with effect lasting 4 to 6 hours, who does not mind reinstilling drops, and when started 2/3, but not all, will get N6, and 1/3 will get 3-line improvement, and then there are little weaker drops which are not yet available. So this is the efficacy point of view. If we start with a clean slate, and not only efficacy but safety also plays a very important role in in how we look at clinical trials. Let's look at some of the adverse events, and sort of trying to take you a little bit away from this jigsaw and trying to give you a perspective. I'm going to take your mind out a little bit to one of the books that I have read recently, and it's called Thinking Fast and Thinking Slow by Daniel Kahneman, who is a Nobel Prize winner. So he talked about the law of small numbers. Remember, because most clinical trials don't report outcomes which are bad, or somehow they are not followed enough, or those numbers are really small. So we are always looking at very rare events in terms of outcomes, right? So let's try and understand how to interpret these numbers. So this is a map from the US. This is not ophthalmology. This is about rates of kidney cancer. So this is the Midwest, and if you see, these are low kidney cancers, or low rate of kidney cancers in some of these states and provinces. So people say, oh, these are rural areas, and they may be eating better, and a lot of other things are happening in there. The air is better, there's no pollution, etc. And then when you look at the Midwest and see who are getting high, so these are highest rates of kidney cancers, you will see, so people will say, oh, they don't eat well, there's a lot of pollution, they eat a lot of processed food, etc. And so, when you compare across these, you will see this is how it is. But when you actually overlap these, and so what's happening? So this is a very low, this is only the, 1 out of 10 is getting cancer here, like 7, 8 out of 10 are getting cancer, but they're right next to each other. And so how can weather impact, and, how can pollution impact all of those? And if you see, all of these are like that. So what is happening here, interestingly, is, the counties which have high rates have actually very low populations. Right, so the denominator is very important when we're looking at some of these rare events. So say this county has a rate of 20% kidney cancer. 20%, that's 1 in 5 men, but then their population is only 5,000. Right, so as the population increases, the risk of cancer is reducing. So imagine 3 out of 100 is 3%. 3 out of 1,000 is 0.3%. 3 out of 100,000 is 0.03%. The numerator remains the same. The denominator is enlarging. So if we are talking about retinal detachment, we need to understand out of how many doses administered did people get retinal detachment, or endophthalmitis, or anything that a rare event you talk about. Remember that the denominator is really important. And unfortunately, a lot of case reports don't talk about denominators. So the small counties have much larger variations than larger counties. When you repeat the same study after 10 years, you will see that 20% has dropped to like 3%. And then absolute numbers are almost, really, instead of 3, you might have 1. Right. So let's see side effect profile of pilocarpine based on some of these, assumptions. So this is a supplemental material from the Gemini study, which enlists every side effect that was actually reported. A lot of side effects which have been reported. Some of them are attributable, and some of them perhaps are not attributable to the drug. So some which are relatively large in percentage, I have highlighted. So conjunctival hyperemia, it's large in this context, but overall it's not large. So 2.5%. When you look at this again, it's too many things happening, but headache is in 14%. And here again, too much where you don't know where to look for. Visual impairment, that is distance vision, is low in 4.3%. And also they have a different category of vision blurred, which is again 2. So overall about 7% have distance vision, which is being blurred a little bit. So that, it's less than 10. So 1 out of 10 will have that little bit of problematic area. And visual field defects, that we think about everything is getting constricted. Remember, this is at 30 days. It's not like a year out. But then still, visual field defect was not really a concern at day 30. We don't have long-term data as yet. Let's look at overall retinal detachment. There have been, let me quickly go back to this video on accommodation and understand the mechanism of retinal detachment. So here, when the ciliary pupil contracts, the posterior zonules contract and the anterior zonules relax, and this is causing traction on the peripheral retina. Once the effect of the drug is gone, this relaxes, posterior zonules relax, anterior zonules contract. I'm going to quickly play it again. And this is relaxed. The lens has become, more increased in anterior posterior diameter. When it relaxes, this contracts in the posterior, so this is basically where the pathology might happen, and you could have tears. Now, there are 3 case reports, or you can even call them total of 5 cases, which have been reported post 1.25 pilocarpine, and all have been, of course, been VT. So this is one paper which talks about 2 cases, and I know Rajesh Rao quite well, and they talk about 2 cases. One is 65-year-old, one is 72-year-old. Both are pseudophakics, and one had high myopia. When you read the full text, you'll realize that perhaps there are a lot of other confounders going on. When you look at this study from Harry Flynn and the group from Bascom Palmer, they talk about 2 cases. One had bilateral RD. Out of that, one I was pseudophakic. The other wasn't, of course. And then the third eye, or the second patient, the third eye, had myopia of -4 or -5. So again, there is something going on at the bottom, there. And then some people have talked about vitreofoveal traction actually worsening. That's when the fovea is quite posterior, so it's perhaps causing a posterior vitreous detachment of some sort. So overall, I think examine the periphery well and don't advise if the patient is more than -5 spherical, the sphere, because clinical trials actually excluded them, and perhaps there is a reason why we should as well. And any risk factors for retinal detachment, you need to advise against pilocarpine, say if there is a family history or there is high myopia, like we already talked about, and there are lattices and some of the other things. So look at the periphery well. And remember, long-term risk of repeated therapy is unknown. The risk of incidence is also unknown because we don't know out of how many got retinal detachment. There are some other studies which talk about compromised visual field and reduced night vision, and that night driving performance is affected, and this is understandable and could happen. And therefore, I think we need to sort of discuss this as well. And do you drive regularly in the night with patients? Remember that about 7 to 10% will have blurred distance vision as well. It's not just near vision improvement. It could be at the expense of blurred distance vision. And if that is happening again, perhaps patients will discontinue that themselves, but then, they might come back to us as well. And others, there are some talks about lens opacity and cataract worsening because, pilocarpine binds to melanin, and then, this complex will alter the, there are some animal studies, but, in humans, we don't know whether this is going to happen. And non-mydriatic pupil, and it's not a non-dilating pupil, rather, after chronic use, this remains to be seen and actually might happen, but then, we don't know. There is acute risk of angle closure glaucoma attack. That's because, the lens is, that the lens is increasing in anteroposterior diameter. So the AC is actually shallowing to about 12 to 15%. Though it is used for treatment, it could also precipitate in those who are very shallow AC. So we need to be a little bit mindful, but that's not common again. And remember that a lot of glaucoma medications develop tolerance, or anything we keep repeating over and over again, including diabetic medications, include intravitreal injections, including drops. The body somehow tends to develop tolerance. So this could also happen overall, gradually, reducing efficacy with time. How long, we don't know that. Right. So remember that when you're looking at adverse events, think about Kahneman and that all the research that he has done, and that it could be one that you are seeing, but then it could be very rare in general. So these are some things at the back of our mind which should always be there. So we've talked about safety, and we've before talked about efficacy, and all of these. So what are the take-home messages, or so what is it we want to take home? So let's put it all together. First and foremost, when you are examining, we need to see it, and remember that it's most efficacious in a 45 to 50-year-old, perhaps a lady, or even a gentleman, has a distance corrected but uncorrected near vision of about N10 to N12 in a photopic light. That is in a well-lit room, that is most of our clinics, at 40 centimeters. The patient is not myopic, is phakic with a clear lens. It has a healthy retinal periphery and no risk factors for retinal detachment. And baseline pupil, it's better that it's a little bit larger, 3.5 millimeters. So we don't have pupillometry in all clinics, neither do we have ASOCT. But then you can look for brisk reactions. Pupils that react briskly will, very likely have very relatively larger baseline, pupil sizes. So if these are there, then, we look ahead. Then we discuss with patients, is it okay for them to have an effect lasting for 4 to 6 hours only, and who does not mind reinstilling eye drops every day to sustain near vision gains, perhaps more than once, and who does not drive at night regularly. I think these are some of the points which we need to, we need to bring it up. And lastly, we need to inform the patients about what is expected, right? So when we start, 2/3, but not all, will get N6. We've already discussed this before, right? So 2/3 will get N6 if starting at from N10, even in dim lighting. And about a third will still get to even N5 with dim lighting at 4 to 6 hours, provided they have high contrast background. Majority will get N6 in brightly lit rooms for 4 to 6 hours, but then you'll have to repeat. It's like if you start at 8 and nobody works for 4 to 6 hours, right? Most work for about 8 to 10 hours. So then what will happen if you are at work at 2 o'clock and your drops effect is gone and you're stranded? What do you do? So you have to carry your spectacle, or you need to carry the drop. One of the two is mandatory. So, the choice is theirs, but then, it's a bit cumbersome overall, but that's how it is, right? And risk of complications, though low, it still exists. So long-term data are not yet available. So we need to tell them that we have, sort of ruled out all these risk factors, but still the possibility of risk is, the complication is still there. And there are perhaps, even dilute drops, which might do the job. You might have to even put it more frequently. They're not yet available. So overall concluding, statement is, pilocarpine in in presbyopia does not benefit all. We need to select well. Patient being the effect will wane off. So repeated instillation is very necessary. Side effects, though rare, can still happen with long-term use. There may be a compounding effect, and so we need to watch out pretty carefully. And then patients to choose with physicians, not over physicians, and definitely not over the counter, because we know that total ophthalmic examination is, especially the retinal periphery, is really important before we go ahead and prescribe these drops. So these are some of the guidelines I thought, or sort of caveats which we can remember when we are prescribing presbyopia. So feel free to get in touch with me if you so wish. Thank you so much, and we'll open it up for discussion.
Thank you so much. I think, Sunny, it was, I think you have a very interesting way to put forth the studies. Actually, usually the studies are discussed, people will doze off that you told everybody, but I'm sure that nobody and everybody was alert, because the way you took everybody in this journey was very intriguing. Now, very quick questions. Probably one thing that, of course, we all know that these were very short follow-ups, like 14 days for the Gemini and the 30 days for the Virgo and the others. So, of course, because we expect these drugs to be used over so many years. So I think that is a major confounding thing that we have seen. And of course, I wanted to discuss especially about the Indian eyes. See, now all these studies, as you have correctly said, are Caucasian eyes. And the N10 at 50, I, as refractive surgeon, see a lot of people at N12, N15, N18 at 50 years in Indian scenario. So I think we do get probably the presbyopia slightly early on. We have probably a higher amount of presbyopia at the same age. Second thing is, of course, the Indian pupils are smaller. So when we spoke about 3.5 millimeter and bigger pupil to have that effect, so they are smaller and our pigments are different. So does the same concentration work okay for Indian eyes, or you require more concentration? So how do you equate this Indian eye scenarios when you compare and extrapolate the studies?
And so,
So
the Indian
this,
data.
Dr. Rohit Saxena, I think we've done a study at RP Center in Indian eyes. Maybe you can also comment after this with this.
Perfect, ma'am. Yes.
So I think, I'm relatively surprised to see almost identical results from the Indian study, where I would have expected slightly, maybe, slightly not as impressive as American eyes. So I would, sort of take it with a pinch of salt in terms of how Indian eyes behaved, and maybe there are some confounders and things like that. And, maybe it has not been done in an urban population. And so I'm not really sure, where it has been done and other things. So, I would say, but then, that, very bright light, and about 60% saw still well compared to 90% in the American eye. So that is more realistic. So there is, so it's real. So it's not that it doesn't work, but then maybe the numbers we need to slide back a little bit. But still that it will still work in half the patients. That's still pretty okay to start using it, I think.
I think we'll also take a quick opinion from Professor Rohit Saxena, who has done, I think, a similar study. Yes, Professor Rohit.
Thanks, Vardhaman, and I'm sorry I'm late. I was traveling actually. As Dr. Namrata mentioned, we've done a study at RP Center. She is also a co-author, in fact, one of the main authors of this paper. As Sabyasachi is saying, we did not find the drug to be as efficacious. The paper is still under peer review. So I'll just say we did not find it as efficacious. We did find a bit of a fair amount of adverse events in them. A little bit of blurring was, I think, in 2 or 3 patients out of 40, if I remember correctly. And brow ache or headache was there in almost 10 patients. Again, none of them actually stopped the drug. They were comfortable, but again, we had done it for just a month, and we are still following these patients up for a medium term. We did an indirect of these patients before and at 1 month to make sure that there was no peripheral changes that could increase the risk, because by that time when we started these couple of reports that Sabyasachi has presented had come. So we were ourselves a little concerned that we may not have a adverse event like a retinal detachment. So that's what we have seen, and a longer term study would be ongoing so that we will get the effect on the long term. And I think the point that is being raised is very important. We need to have actually, for a drug that may have a little variable response, we should have a dosing or a phase 2 study in India so that we are able to reach the optimal concentration. And it is possible that there may be, different populations have different concentrations for which they will be the most suitable for them. So I hope that this availability of this drug will spurn two things. One, the awareness about presbyopia, and we know that even the census has documented that presbyopia as a cause for difficulty in work and loss of work hours or days is an important problem world over, particularly in India, and therefore highlight that spectacles are so easily cheap, over the counter, if you may want to call it, available. We should, as ophthalmologists, push towards correction of presbyopia in all places, including workplaces where close work is being done, and to spurn research on this drug. Although I would say that this would be an urban-centric, a little more difficult to access, because it would be available only in urban areas, and I'm sure this should be a prescription-only drug. It should never be allowed as an OTC at all. Again, what Sabyasachi mentioned. So,
yeah. So thank you for sharing your results, Professor Rohit.
Which
Ma'am.
to be clarified here, Vardhaman, is Rohit, what was we used the drug pilocarpine that was being used was made in our own ocular pharmacy.
Yes, absolutely.
Concentration. And
Yeah, we made it in our own pharmacy.
We did
1.25%?
not use any
1.25%, yes.
Okay, okay, that's great. Wow, that is a remarkable thing to know, actually. So in this case, of course, the thing that Sabyasachi just spoke about, the vehicle, because there is this molecule and there is a vehicle. So I think vehicle is not causing any confounding in the results that we have. And as Sabyasachi said, I would like to also know from both Professor Rohit and Dr. Murlidhar also, because both of them are quite in research about this, the vehicle producing such a good result in the Virgo and the Gemini study. What do you think? Even Dr. Namrata ma'am.
So Sabyasachi knows what is the vehicle. He did mention that he feels that vehicle itself, was
facilitating.
Has some efficacy. So what do you think, Sabyasachi? What is the vehicle? No idea.
You might have no idea, but then it looks like it could have some sort of boosting effect on it, especially when you compare with the Indian data. It's better.
There are studies in literature where pilocarpine has been combined with other drugs also, like pilocarpine standalone has not been used, but other drugs like astringents have been used, nefazoline has been used, so many other drugs have been used, either to combat the side effects or to make it more tolerant. So would you want to comment on that, Sabyasachi? What about those drugs?
I only think that maybe there is some anesthetic like a proparacaine or something. I'm not really sure, but then that also has a little bit of
so
patriotic.
it could be placebo effect also, because if you the European study on the ocular hypertension, when they did compare with the dorzolamide with the placebo, the IOP reduction in placebo group was 15% as opposed to 19% in the dorzolamide group. So it could be so many factors. The patient feeling that he has been given the drug and he feels that he has been improved. So placebo effect cannot be ruled out in any study where the placebo has been used.
I'm sure FDA would have checked for the vehicles, activity, and I'm sure even the company would have, because again, it would look, it's not going to look good if you're as mentioned versus dorzolamide. So 19 versus 15 may not even come statistically significant, and that kind of makes your result very poor. So I'm sure it must be a neutral vehicle. Most of the time, they are very careful. I think in the Indian study, it was artificial tears. The effect of artificial tears per se may not be there, but as mentioned that, just maybe, acting to clear the vision a little or possibly, but otherwise for the drug, it may help to enhance the duration of contact. So that could be one of the ways in which they may have or may progress to work towards increasing the, effect of the drug for a longer period of time.
So other question to both Sabyasachi and Dr. Rohit, maybe Dr. Namrata ma'am also can speak about it, is what about pseudophakic eyes? Because now here we are talking about the phakic eyes. In India, we see a lot of people get cataracts early on in their sometimes 40s, 50s also. So what about pseudophakic eyes? What is your presumption how this drug should behave? Because of course it is just in a way meiotic. and that action continue.
I feel as of now we should not, and no study has been done to study it in pseudophakic eyes. So as of now, I think it cannot be given for pseudophakic eyes with the current availability of the literature. And unfortunately, the eyes where retinal detachment did occur, most of them happen to be pseudophakic. So I think pseudophakic should be an exclusion criteria for this.
Or at least with care. So you need to be sure that you not only do a retinal exam at baseline, but maybe consider, on a periodic interval to make sure that these patients do not have a higher risk of retinal changes. But it's very early in our experience of the drug. So even in the US, it's been just 3 years for an OD drug. And what we found in our study was that the effect of the drug does wear out by 6 hours or so. After that, it's not really significantly better. So obviously, if it's working hours, you may want to put the drug at least twice during the morning or morning and afternoon to be really effective for a 12-hour work day. So which is pretty common in India, unfortunately. So I think that it becomes more important for us to be a little careful about the problems, particularly, although I'm not sure how frequent it would be, but even angle closure glaucoma has been reported with the use of pilocarpine drops. And India, angle closure being, or shallow angles being that much more common, it is important for us to be a little careful when we use this drug.
Because it moves lens iris diaphragm forward, and angle closure, the occludable angle is very high in the Indian scenario. So we have to be very careful. So otherwise, in angle closure, when we only use pilocarpine once the iridotomy has been done in angle closure glaucoma. So otherwise, in an occludable angle, it can cause a problem. It's not even acute angle closure, otherwise also, because it can lead to the chronic angle closure. We see lots of patients slowly converting from open angle to closed angle, and this drop can worsen the situation.
I think especially in Indian eyes, this is to be kept in mind. I think for our delegates who are attending, that should be important.
So otherwise also, when he presented Sabyasachi about the visual field, we had done around 15-20% patients, 15-20 patients, 2% pilocarpine, visual field before pilocarpine and after pilocarpine, and the visual field severely constricts. So it does have effect on the visual field constriction, because people will become small. So artificially you are creating the visual field effect. So it improves the depth of focus, but the visual field will be slowly restricted. The other problem would be the glaucoma. The undiagnosed glaucoma is a huge problem in the Indian scenario. So because majority of the patients when they're diagnosed, they're moderate severe. If you start using pilocarpine in those groups, they definitely have more field restriction and more other problem which we do not want at this point in time.
So in fact, I think all ophthalmologists who are prescribing will have to be very well versed with gonioscopy also.
Yes, absolutely. Gonioscopy, peripheral retinal examination, everything.
So skills are mandatory for the ophthalmologist to have that time. So we'll come back to Dr. Rajul sir, and we'll go back right now to Dr. Muralidhar, because I think he has done also a lot of literature review in the last 1 month. And he actually has nice insights to share. So I think this is open to you, Dr. Muralidhar, please.
Thank you, Dr. Vardhaman. So what I found is in Indian eyes, where, as you rightly said, the mean anatomical pupillary size is a 2.9. And also, the pseudo accommodation effect is directly linked to the amount of meiosis. So the degree of meiosis possibility induced, if you compare with the Caucasian who have a little over 4 millimeter, is significantly different. And the second important point, as you rightly said, presbyopia onset at least 5 years earlier in Indian population compared to the Caucasians. And this perhaps may be related to the loss of elasticity of the lens. So therefore, pseudo accommodation ability of a pilocarpine is much less efficacious. Third, importantly, since in a pigmented rays, pilocarpine has an affinity for a melanin. So probably, the effect which start, there may be a large lag time compared to the Caucasian, and drug tend to stay in the uveal tissue for a much more longer time compared to the less pigmented rays. So that's also one of the important point. And the other side effects, which I believe, it does affect the blood aqueous barrier so much, it can actually trigger a subtle inflammation. You can also have a pigment dispersion. And these are all, certain concern when we start using these drugs, multiple times in a long time. And also India is a diabetic capital. In a long run, since in all these studies, as we rightly pointed out, 14 to 13 days, so we don't know the true washout, effect of pilocarpine. If we use it, let's say for a decade, somebody who starts at 40 until 50, and it does produce irreversible pupillary changes. So it may, obscure, retinal view and a better delivery of laser, particularly when there is an incidence of having a, diabetic retinopathy. And of course, it complicates our cataract surgery and such kind of a distorted pupil where we may not be able to offer them some of the fancy lenses in the future.
Yeah, I think nice insights, Dr. Muralidhar. I know that you have spent a lot of time in going through all the literature on this, and I think all these insights are also very important because, as you said, it is a long-term drug that we are looking at. When we spoke about the low-dose atropine, because the main issue was that it is going to be used for long run. All the aspects that Dr. Muralidhar has just shared, Dr. Namrata ma'am, would you like to say something on this or ask anything?
No, I think Dr. Murali's made relevant points, and these are some things which we should look into. But additionally, these are things which are not tangible in the short-term period, and all of the points that he's made are for long-term results and outcomes. And I think we don't have any long-term studies as of now. So, like Dr. Rohit said, that we have studies only till 3 years follow-up. So I think that is something which is to be seen how all these things translate on a long-term basis.
Yeah, absolutely, ma'am. And I think
Vardhaman,
probably,
can I
yeah,
butt in a little bit? So these have been used for post LASIK eyes,
sure, yeah.
and they have done pretty well. It's been published in JCRS. About 39-40 out of these Gemini eyes were actually LASIK, post LASIK eyes, and they did very well. Remember, those are the ones who are really want to
39 to 40 eyes were post LASIK eyes. Okay,
yes,
that's
and they would really
half 1/3 of the population of the
yeah. So out of the 160, about 40, so one fourth, right? And then remember, these are the ones who are very keen to not wear glasses, right? So it's going to be a scenario where they are post LASIK and they want these drops, and so they also did pretty well. And also.
Yeah, again, the same thing. Now I'll come to Dr. Rajul Parekh, sir, because
the same thing, Sabyasachi, is only 15 days to 1 month follow-up.
Yeah.
So if we have a long-term follow-up, then we know
We
the
don't know, but sir,
complication.
the thing is, we don't know.
That's what I'm saying, that if we have a long-term follow-up, then we really will know that what are the potential complications, the problem. See, one thing from pilocarpine, 1% and 2%, and 1.25% will behave more or less similarly. Pupillary meiosis, the cataract surgery will become difficult. Of course, we can manage, but we artificially will make it more difficult by using the medication. That we know it will happen, even if we don't have data at this point in time. So the other thing, angle closure, that we know, because 1%, 2% we are using for decades. The only thing about RD, personally, I've seen few patients, but yes, all were myope. So the normal presbyopia, whether the risk of RD is really increased or not, that I don't know. That the long-term data is required. But otherwise, my main concern is that what benefit we are giving, other than patient who's really motivated to not use the glasses, compared to the harm. So at this point in time, whatever the data is available, I don't think that we are giving more benefit. I think the harm is more than benefit in view of lack of the data. If we have long-term data, then it's a different issue. Otherwise, the angle closure suspect is high in India. The meiosis will definitely happen, which will make the cataracts, because everybody will get cataracts sooner or later. Though there are some data, the animal studies which says that the pilocarpine do increases the cataract formation earlier than the normal population. So all these factors look into it. If I have to analyze from the evidence-based medicine, I would say that the benefit is much less compared to the harm the drop can cause at this point in time. Once we have a proper long-term data, then I don't know. Yes, Rohit. Dr. Rohit, I wanted.
Please complete your point. I would just add on to that. I'm just listening.
I think this is what. So at this point in time, I think that whatever the limitation we know, the long-term RD data, I don't know. Nobody knows. We have to see. And the other thing, it is at least twice or 3 times a day. The iris pigmentation is more. The pilocarpine may work little less, 1.25%. Whether we have to go higher percentage, I don't know. That also we need to look. And you are saying that you are looking into the different formulation. But at this point, I have to conclude, I would say that the evidence suggests that the benefit is moderate and the harm is definitely there, which we have to look very carefully.
I think as sir said, patient selection is very, very crucial, especially those undiagnosed glaucoma patients, and long-term use has to be always looked at. I think then we'll go to Dr. Rohit. He's going to make a point, and then
I just wanted to add that in our experience, we found that the add or the benefit of these drops was about 1 to 1.25 diopters. So that is the add they are able to achieve with the meiosis that can be produced in Indian pigmented eyes. So it would be useful in an early presbyope who is, as mentioned, not very keen to wear glasses. But once the need starts going beyond 1.5 or more, the success of the drug will decrease, especially if the person wants to read very fine print. So if you can get away with, a little larger, only the headlines of the newspaper, or, big tickers on the,
But basically, in the smartphone era, everybody wants to read the small print because the phones are small.
and also slightly enlarge the font size.
So then you have to do other thing.
I think there is a difference between being reckless and actually being circumspect, and then actually just being go out all out. So we can't be reckless, and we can't be really positive, but but then that scientific approach has to be there. If there is no data, we need to come up with it, right?
Exactly.
I mean,
That is what I thought.
So I think that is very important to understand, that you can't just just downgrade it and say don't use it. I don't
No,
think that's the best approach.
absolutely not.
Not
What
the
I
best
wanted to
approach,
say
yeah.
was we have come out with a very nice list of, where caution should be exercised.
Yes.
If and when this drug becomes available, it's important for the ophthalmologist to be aware of this list of diabetics, family history of glaucoma, because maybe at 40, 41, 42, the patient may not be glaucomatous.
Yes.
So, a family history of glaucoma, someone with developing early cataract, a diabetic. So all these become our, list of caution where while we as, a group of ophthalmologists are gaining experience on the drug, we should be careful and maybe avoiding these patients. And like I mentioned, a healthy, non-diabetic, young, early presbyope with a mild need may be beneficial.
So,
Yeah, I think
so basically to add, Dr. Rohit, one thing, Vardhman, that whatever said and done over the counter in India is the norm.
Yeah.
So we have
All
to
these
push,
things-
we have to put a strategy and push it very strongly that patient realizes that they have to take a prescription and ask a doctor, whether ophthalmologist, whether the drug is useful or harmful to them. Otherwise, the OTC is the norm in India. Whether whatever people say or whatever we say, they can get anything and everything over the counter.
Absolutely, sir. So basically, what we understood from also Sabyasachi's talk and from the discussion is that, okay, that's shown effect in specific situations, in specific population. But of course, there are important risks, and you have to make sure that the patient is screened very, very judiciously, very properly. And of course, without that, patient should not be given, and there should not be no indiscriminate use, because the population is so large. As we said, that it is the commonest refractive error in the world today. The population is so huge, even that 0.1, 0.2% will also be a huge population of complications. But that indiscriminate use over the counter is what we have to for sure fight it out. So I think I'll go to our treasurer who would like to make a comment, Dr. Mandar Paranjapesha.
Yeah, thank you very much. It was a very interesting discussion and a very nice presentation by Dr. Sabyasachi. Most of the points have already been mentioned. I would like to just make a philosophical point that what's wrong in wearing glasses after that age. So I think we should not be overzealous in promoting any product for which we don't have any robust scientific evidence As Dr. Rajul said, that unfortunately over-the-counter availability of any drug is a reality. So, and one more thing which we need to remember is that even if you prescribe this drug in a particular dose, we're pretty much sure that the patient will be overdosing themselves, and that could create potential problems. So I think we need to also have a list of do's and don'ts given to the patient along with the prescription of the drug when we give the prescription, because we may give the prescription once, but the refilling of the prescription will be done by the patient on their own. They won't come back to you like in the West, where you need to have a doctor's prescription to refill the drug. So that won't happen in our scenario. So that is something which I think we need to keep in mind when we start using this drug. And one more thing which I would like to say is that this is just the beginning of probably a pharmaceutical sort of intervention for a common ailment or a common defect that we all develop with age. So this may sort of give rise to maybe something or put us in a direction of something more interesting. So everything comes with a caveat. We all should be aware of those caveats. We have to make our community and patients aware of those problems and don't prescribe the drug. I have one question though. There is one more product by another pharma company of a lesser concentration,
1%,
which they have never promoted as a
that's
drug
what I was
for
telling
presbyopia.
Varma. Yeah, so Mandar, the name is very clear. Mandar,
Clear,
the
clear,
name
exactly,
is
exactly.
clear.
Actually, they cannot market it. They do not have the permission. That's why if you will see, there is no pack insert in the bottle. The pack insert has to mention the specific reason for which the drug is permitted. So 1% to 2% have already been approved for glaucoma.
Yes.
So actually, that is why 1.25. Although I'm again unclear as to 1.25 because 1 or 2% Pilo is priced at 40 rupees. And 1.25% is priced at, I think, 340 rupees. So, I mean, they claim that there is, better stability, I think a better vehicle in it. But I don't know. Sabyasachi, any experience on why it is priced? Is there any literature or any data they gave as to why it is more, higher price than even probably 2% pilocarpine, where the amount of drug used is more?
So in the US, the VET cross costs $80. It's 3.5 ml and it $80 and about $85, and it's not covered by insurance. So the uptake has been, very lukewarm. And so I've talked to Rajesh Rao, who's one of the authors of one of those papers.
It's been lukewarm. The response has not been that great.
No, that's because insurance doesn't cover for this. And so you're looking at $6,000 a month for the whole year. It's a substantial amount. And then when you add it to 10 years, that's quite a large amount to pay out, right? So most people don't want to use those drops. That's simply because of logistic reasons. But here, they're pricing it costlier than existing pilocarpine. I think we should ask the NTOD representatives maybe.
Yeah, because of the pH, which they keep talking about, that you have to optimize the pH with
buffer and the artificial tear in it.
Right.
Because of that. And regarding 1%, 2%, which are already available, they can't promote it, or they can't say off-label. I mean, they can't promote the off-label use of that particular drug for presbyopia. So that is why they probably can't market it for that.
Although they've given a very ingenious name to it.
Yes.
So basically, now
they are not doing very open marketing. They are very subtly.
So that is a very subtle marketing, or very intelligent marketing, or clever marketing.
Yes.
But I don't know how many people actually use it for presbyopia.
I am using it for angle closure now, play to iris, because I like 1% is much better than 2%.
At least I think glaucoma people are benefited by now a little more availability of pilocarpine, because earlier suddenly it had gone out of the market.
Yeah, 1% is better than 2%.
Yes.
In terms of base meiosis.
Glaucoma people use pilocarpine in their practice routinely. Have they encountered or attributed retinal detachment cases?
So, ma'am, I very rarely use pilocarpine, since so many other molecules are available, much better molecule. So, and when the prostaglandin is given, the add benefit of pilocarpine is only 1 to 1.5 millimeter mercury. So, doesn't make any sense. So some people use it, but I use pilocarpine only in a play to iris post iridotomy. So my indications are very limited. But I have seen few RD. So because some people use it for RD, but as I was talking that most of the patients were either myope or pseudophakic. So I would not say it because of maybe pilocarpine increased the risk, but they all were myope or
Myope of high degree or a small degree?
Some were I don't remember. The last patient I had seen was -6. That other patient I don't remember all the data.
I think
The other thing it do causes the aqueous blood, the aqueous barrier, breaking the barrier. So risk of inflammation that also increases in pilocarpine.
Because now we are talking about the detachment, I think we should go and speak to our retina expert, Dr. Sasode sir, who has a humongous retina experience of so many years. And I would like to probably invite Dr. Atul Kadane ji, who is our secretary, who has some questions for us.
Actually, I just want to ask Manoj that we know there are so many drugs with having so many side effects, but we still use it. The same. So, is it really that the fear of retinal detachment? Will you favor the pros as opposed to the cons? As I say, what is your experience that it is really that much you have to worry? As the Sabyasachi has told, the denominator is the important. You may see the cases, but will it prevent us from prescribing to the this presbyopia or maybe this presbyopia drop pilocarpine?
Yes, it is a very good practical questions you have asked. Basically, in my last 25 years of practice, I have not come across a single case of retinal detachments because of pilocarpine. Maybe I have missed the question to ask whether he was using pilocarpine or not. We are seeing everyday retinal detachment case, but the correlation is not justifiable as far as my practice has gone years together. But the literature, what we have seen, many people are mentioning that this is a risk factor, and it is a valid science where we know that the iris lens diaphragm goes forward and causes the traction on the vitreous base, and that can create a retinal tears, particularly in cases where they are having precursor lesions, early lattice degeneration or peripheral retinal degeneration lesions, or who are high myopic or having the history of retinal detachment in the family. Those patients should be screened properly before starting this one. Now, here the question is that who is going to come to you if they are going to buy the drops on the counter without the ophthalmologist's prescription? That is one thing. Even if the ophthalmologist is prescription it, whether he is well versed with seeing such patients after dilating the pupil. Dilating pupil and seeing the peripheral of the fundus wide is a scleral depression. If they are not using it in their routine practice also and not trained to do that one, and they are giving the prescription of pilocarpine, that is also a big question that how to solve this one. Whether all these patients, like patients who are undergoing the LASIK or refractive surgeries, are supposed to be screened by the retina surgeon. Whether this is again a question to all those people who are going to take the pilocarpine will be seen by the retina people. So the literature says that there is evidence of pilocarpine induced retinal detachment, but in my own practice, I have not come across this type of thing, because maybe, as Rajul sir has said, that nowadays hardly anyone is using the pilocarpine for the glaucoma management.
One question to all the panelists: will it be as a gap fill arrangement? As the spectacle get broken and this site of drops might have taken that 2-3 days, he can use, and he can. The people are using ready-made reading pen too instead of that. Will that be one of the indication for this drop? Because considering all these side effects and the things, but if only for the making the gap that before he makes his spectacle, will it be used?
The thing is that, see, the thing why I would like to answer, risk is not related to the how many times and how many days you are using. If it has to occur, it will occur in a single drop also, or in 1 or 2 days also, because these are the high risk patients.
Actually, in the cases that Sabyasachi has just mentioned, the RD was seen within a week and 10 days, 5 days.
That's what I was also talking. So it is not a stopgap. Basically, you should know that what is the risk versus benefit. today's talk or today's topic is on that forum only. We don't, ophthalmology has no control over DGCI or the companies or on the whole population of 140 crore. Where we stand actually to see that if patient comes before you, before starting it, or in between also if he comes, what is your duty or what you should counsel him or evaluate him and give the warning sign.
So basically, coming to
I
that
think
question,
Vardhaman,
yes, sir.
counseling is very important because side effects are there, but they are very rare or very few. So we have to rule out the risk factors beforehand.
Absolutely.
And of our own, we will not prescribe the medicine. Patient will ask us.
Yes. Yes.
So that's why we have to counsel the patients and what are the risk factors we have to explain to the patient. That is the most important thing. And then you can prescribe the medicine. So every medicine has its own side effects. Still, we prescribe the medicine.
Right.
So we should tell the patient that these are the side effects that can happen. So means you have to keep follow up periodically. That is
Yes,
also an
and
important message.
I just want to add to this one is that Dr. Muralidhar sir has told very clearly that there is a pigment dispersion, there is a rigid pupil. That is more difficult for everyone, including retina as well as anterior.
It is very difficult to examine the
patient
retina.
comes for the retina evaluation and his pupil is not dilating. If he is gone for the cataract surgery also, that is a problem, even though it is a solvable. I have seen many people with this pigment dispersion looks like an cornea gatata. And that it becomes very difficult. Everyone won't have this specular microscope to evaluate whether this is drug-induced cornea gatata or inherent gatata.
I think Sabyasachi mentioned very clearly, and I think it's very good that we actually appreciate that a new drug has been brought into the market, something that was available in the West. But it is actually our duty to see where and what is the place of this drug, irrespective of what company or media actually hypes it to. It's not only our duty, but it's our responsibility to make everybody aware, make our own understanding assessment of the risk and the benefit and convey it to the patient so that the drug finds its optimal place for this indication.
Perfect.
That's, I think, our responsibility that we should carry forward.
Vardhaman, I have one or two questions.
Yes, sir.
Can I ask?
Yes, sir. Please, sir.
Yeah. What about the intermediate vision? What happens to that? Because most of our people are working on PC. So what happens to the intermediate vision?
Yeah. So
That is, I think, not
so I can't offhand remember the numbers, but we had also checked the intermediate vision because that was also one of the concerns we had. So we had checked all three distance, intermediate, and near vision, and there was a mild improvement in the intermediate vision also. But as I said, can't offhand remember those numbers because we were, of course, concentrating mainly on the near. We were checking the pupil size, the range of accommodation. So. But I think it would, mildly benefit these patients also the, intermediate vision.
So trials have actually reported on. Trials have reported on in intermediate vision in dim as well as bright light, and
Yes.
it pretty much matches that 65-70% number.
Yes.
Can we recommend our PC users to increase their brightness and contrast so that they will have added effect? Can we recommend like this?
So we usually recommend to do the reverse, to actually reduce glare, reduce, the brightness, reduce the screen. I mean, I would actually tell them to reduce the screen brightness and increase the ambient illumination to reduce the strain and the, problems on the eyes. So I would say that it would be not good to actually increase the contrast coming from the screen or whatever to, make the temporary pupillary constriction to happen. But that actually would tend to increase the strain on the eyes.
And second most concern is that while on the drop, if patient is driving and his visual field is constricted, how can he see the sideways? And what happens to his driving safety?
That can be, I think that is again something which we need to counsel.
Again, usually fields are not shown to be very significantly constricted in these group of patients. But yes, it's a concern. It may be a concern over long term when the pupil over time will become a little more stiffer and may not dilate. But I think if I remember the studies correctly, there was no significant change in the field.
But the same question, Dr. Santosh sir, I was having, if the pupil is small, constricted, how this patient will be recognizing the floaters and seeing the curtains in front of eyes? Literally, it is a practical problem.
Dr. Rohit, in your trial, did you do, monocular versus binocular? So one of the...
Yes, we did. We did monocular versus binocular. Again, I don't think there was too significant difference. Of course, I mean, we concentrated on the big things, and I can't offhand remember, but yes, we did monocular versus binocular.
The Indian study has done it. The Indian study has done it. So it's about, about 3-4% better when you look at binocular. They have reported right eye and left eye separately, and then binocular separately as well. Only the Indian study has reported. Gemini and all don't report, but the Indian
which
study
is I guess a normal physiological behavior.
Right.
So
yeah.
One strong indication what I feel for this drug is when the patient wants to go to special occasions or some functions, he can put that drop at times, just like our cosmetic contact lenses.
See that is, again, there is a
But again, the same thing, single
this
drop.
drug 101% causes some heaviness in the head as well as the discomfort. We just put a drop before any iridectomy. You see that if you delay it for 1 hour or 2 hours, the patient will come and ask you that do the whatever you want to do it, or I will come later on, because the headache starts immediately after putting that pilocarpine. So if he has to go for any special occasion, then it should not be advised at that time.
He'll have headache at the same time.
But it is it's only around 10%, I think, what Sabyasachi has showed.
That is the study, but if you see, put a pilocarpine and ask him to
2% actually.
for 3 hours in your OPD and see
that
what.
is 2% actually. 1.25% may not cause that much.
Yeah.
Occasions like, somebody is going for an important presentation, somebody is going to attend a wedding, somebody wants to go for a kitty party, things like that. So there are a lot of occasions where, we will come across patients who want that.
I think pilocarpine is unique because the population involved is huge. But then this problem of people using steroids when they should not be, or using cosmetic contact lenses when they should not be, and there are several other things, remains mainly because everything is available over the counter. Antibiotics indiscriminately. So that sort of a thing is there, and that applies not only to pilocarpine but to a lot of other things.
Absolutely, ma'am. I think that is the main crux of the story, because indiscriminate use for a drug which is actually meant for such a population is basically something that we have to deal with somehow in a right fashion. And that's why we were actually planning to also invite the president of the Chemist Association in Maharashtra to actually see to it that how it can be avoided. So basically coming to the examination, so apart from doing the gonioscopy and peripheral retina exam, and also maybe the lens opacity, because that people who have central opacities in the lens may actually have drop-in vision, and both in dim condition as well as in the mesopic condition also, if it is a central opacity in the crystalline lens. Anything else you would feel anybody else would like to add to this exam?
So there is an emerging scenario in US, because these two companies bought, the raw material API at premium. Now people used to, routinely prepare glaucoma preparation, 2%, 4%. There is a scarcity of, pilocarpine for a glaucoma use.
Right.
Do we see such kind of a scenario in case if it gets popularized in India? So that is the biggest concern what we have now.
That's true. That's a scarcity.
So inflammatory conditions and chronic arthritis patients, they do get uveitic. So I think we should avoid pilocarpine in such patients, I think.
Yes, sir. But Vardhaman, what I feel that in my practice also I have seen, as far as the ophthalmologist goes, those who are presbyopic, as Dr. Mandar has said rightly, that what is the problem in using the spectacle? What is the problem in introspection ourselves also? How many ophthalmologists themselves know that what type of varieties of presbyopic corrections are available and this progressive lenses, multifocal progressive lenses, and all types of the fancy items are available in the market, and they themselves are not aware. We have to. I have forced many ophthalmologists to use these wide field progressives and multifocal progressives, and they are now happy. If this is the situation in ophthalmology itself, then how can we expect the good thing from the common man's or society? So the rightly said that first ophthalmologists who are presbyopic, they should start using various types of presbyopic corrections and they should know that what exactly it is available in the market. And that is also not known to many ophthalmologists. That is what
this is again going to be a question to the everybody. If you are start prescribing it, the person will going to ask you, why not you are not using it? The same way as the LASIK patient asked us, you are wearing glasses and you want us to remove the glasses. The same question you have to face them.
But actually in LASIK...
So, Vardhaman, just I want to put one question to Namrata ma'am and you, because you are a refractive surgeons.
Yes,
so,
sir.
there are so many things available for presbyopia correction.
Yes, sir.
So, how you, this pilocarpine stands in this presbyopia treatment? How will you compare with others?
So, I'll let Dr. Namrata ma'am first answer and then I'll speak. Yeah. Yes, ma'am.
I think presbyopia is a very unique kind of I shouldn't say a problem, of physiological state. We do use glasses, and this actually I became aware when I became presbyopic. It's kind of complicated and it's kind of difficult because if you are a myope like me and using contact lenses, then you can do you can, for some time, for a couple of years, you can wear under correction and get away with it. Then glasses, of course, we can use. We may not want to. That is a different thing for cosmetic reasons. Third thing that was being talked about was multifocal contact lenses, and not everybody is comfortable with it because with multifocal contact lenses, your contrast does go down. And apart from that, you have presbyopia inlays, which again, of course, are again not very popular. Short of that, you have refractive lens exchange or multifocal lenses, or what we say presbyopia lenses, presbyopia correcting lenses. But I think they also have a role only when you have a cataract. So in case you want to, and I don't know how many ophthalmologists would want to, really get that done, because we all have to operate. And whatever you may say, the light gets split with any kind of multifocal lens for distance, for near, for intermediate, into some percentages, which will vary with different kind of lenses. As far as the inlays are concerned, their results are again not very consistent. So as far as presbyopia is concerned, I don't think there's a real solution to it as of now, and something that people should work on, because I think that is the commonest refractive error, as Vardhaman and all of us know. And I think there's still not a clear solution to it.
Yeah, I think I of course I agree with everything ma'am has just said. And from the point of the ophthalmologist, ma'am has narrated very nicely from the point of the patients. If I have to put, I think the main thing, as Dr. Rohit said, maybe the place for this pilocarpine in this armamentarium of so many options of presbyopia correction will be a typical young presbyope who is a immetrope and who is looking for basically a solution which is non-invasive, possibly reversible, customizable. So for them, I think this pilocarpine drug may work well after a very thorough evaluation by their ophthalmologist. Of course, I foresee somehow that if it becomes very popular in India, this drug, and it is not so much in the US, but I think the need or the, let's say the demand for refractive surgery correction for presbyopia will go up actually in the future, because as we have all seen, this drug is going to basically have less and less efficacy as we all become more and more presbyopic. So as the patient becomes close to 47, 48, 50, beyond 50, these patients will look for solutions because now they are not used to using glasses and they would like to actually get rid of them. And that is when the current solutions of doing the blended vision or the lens exchange and all those things will also come into play. So as ma'am said, actually, when there are too many solutions, this is what is a favorite quote of my mentor, Professor Pilocarpine. He says that when there are too many solutions, that means nothing works perfectly well. And we have to really select a particular solution for that particular patient. Yeah, so I think that is the gist of it.
Even if you talk of Presbyopia and Presbyon, even that is not there, where it.
Yeah, it's
So
not.
presbyopia, yeah, like
So
with
you-
myopia, we know we are there, but with presbyopia, we know we are not still there.
No, still not there. Yes. Yes. Perfect. So I think in terms of the exam and everything else, I mean, we have so far understood that, of course, from Sabyasachi's point of view and all the studies that he has shown, that yes, definitely it's a welcome drug. It has, in a way, shown results in both the Gemini, the Virgo, and the NEAR trial, also the trials which are done in India. But for sure, the biggest thing that is in front of us, the elephant in the room, is using it indiscriminately without being supervised by ophthalmologist. So I think this is what we have to all tackle, because there will be more pharma companies which will come up with this drug with the current, let's say, hype that we have seen in the media by different groups for sure. So I think before we conclude, probably I would like to go for the concluding remarks from both our chairpersons today, both Dr. Namrata ma'am and Dr. Agarwal sir. So I think we'll begin with Dr. Namrata ma'am. Ma'am, I think we have discussed the gist of everything, and I'm very, very happy that the science was, I think, quite threadbare discussed today, and the way Sabyasachi took us through with everything could have not been done for a common ophthalmologist on their own. So I think this is a webinar that they can go back to even 2 years from today to understand how it works, what are the studies and everything else. So thank you so much, ma'am, for being a part of this from the AIOS Scientific Committee. And I would like to now request you to give your concluding remarks.
Dr. Lalit sir is there, so we can ask him also.
Sir has left, I think.
I think left. Okay, okay. Ma'am, please go ahead.
I think it was a good webinar, and in terms of the science of use of topical pilocarpine in presbyopia, many congratulations to Dr. Sabyasachi. I think it was so difficult to understand, and it is, those figures are very difficult to understand and interpret. He made it so simple, by putting all the trials in boxes and by making us understand actually visually what, we are expecting and what should actually happen. Coupled by all the expert comments and the studies which have been done in India, I'm sure Dr. Rohit Saxena is going to follow up his patients for a longer period of time in order to give us the long-term results of what we are talking about. Having said this, whenever a new drug comes or a new indication comes for a drug which is existing, such controversies are bound to occur. But important thing is that if you don't try them in selected patients, how would you know whether it works or not? Having said that, it is also important to know and understand that exclusion criteria and inclusion criteria should be very clear, and we should counsel our patients appropriately. And of course, over the counter, like for other drugs, for this drug also, over the counter prescription of the drug should be avoided and should be only done. And this is one condition which involves all the specialists. Involves a glaucoma specialist, a retina, vitreoretina person, a refractive surgeon, a general ophthalmologist for that matter, and even optometrists. So I think this is like a pan-ophthalmology kind of a involvement, and so everybody needs to be aware about this.
Thank you, ma'am. Thank you, ma'am. Yes, sir. Dr. Agarwal, sir, please. Yeah.
Yes. Thank you, Dr. Vardhaman. It was indeed a wonderful webinar. I am very grateful to Dr. Sabyasachi and all panelists for enlightening us in regards to the newer medicine, that is pilocarpine 1.25%. Actually, pilocarpine 1.25% has its own merits and stand to treat presbyopia. Nevertheless, it has its own side effects as well if used for a long time. So it is quite evident that number one should use it in indicated patients only, and patients should be evaluated thoroughly to rule out any risk factors. Second, patients should be clearly counseled about its probable side effects and asked to follow periodically. Third, as a society, we should inform government, chemist association, FDA, and pharma company about the side effects of the medicine and should prohibit its use indiscriminately and OTC. It should strictly be given on the prescription of ophthalmologist only. It is also advisable and recommended that pharma companies should unveil any medicine alike pilocarpine, in the doctor's conference rather than in public domain, in order to avoid havoc or chaos in the public and preclude devastating effects widely. I am indebted to Dr. Namrata ma'am, Dr. Lalit Verma sir, Sabyasachi, and all the panelists, AIOS, MOS team for this webinar, which and for their sparing valuable time for this webinar. We have a good discussion, and it will definitely help all our colleagues to practice this type of medicine in their routine patients. Thank you very much. Over the Vardhaman.
Thank you so much, sir. So I think, thank you so much. I think you have given a great gist of it, what our ophthalmologist should follow before prescribing this drug, and also to make sure that this does not become available OTC and discriminately used, to take help from our Chemist Association, FDA, and the pharma companies as well. So before we go to the vote of thanks, very, very quickly, maybe half a minute comment from Sabyasachi and Aditi, and then we'll go to vote of thanks by Dr. Atul.
I would like to thank everyone involved for giving me the mantle, like I said right in the beginning, and I hope I have done justice to it. Before closing, I would like to say that if someone is planning to do future studies, try and look at the pupil dynamics. So do an ASOCT in mesopic as well as in scotopic as well as in photopic conditions at the same visit, so that you can actually see how much the pupil is moving and whether it's actually getting stuck or not. So that will actually give us evidence-based recommendations going forward as well. So thank you so much once again, and I hope it was helpful to everyone.
Thank you so much. Thank you so much, Sabyasachi. Yes, Aditi, please.
Yes, it was wonderful webinar giving scientific as well as like experience-based insights into the drug and usage. I feel our main challenge is going to be avoiding the OTC use of the drug, because like we have seen many side effects in spite of counseling patients who use the steroids, etc. But the main worry in this drug is the population which is going to use this drug is much larger than a population which generally tends to use the steroids. So I think that is going to be a big challenge, which we need to handle it efficiently with a good counseling, with the help of all the chemist and drug association. So yes, but wonderful insights into the evidence-based things on this drug. Thank you.
Thank you so much, Aditi. Yes, so we'll go to the final vote of thanks by Dr. Atulji.
Thank you, Vardhaman. As an official vote of thanks from MOS side, I am very much thankful to the chairperson, Dr. Namrata ma'am, Dr. Santosh Agarwal sir, to our speaker, Dr. Sabyasachi, and all the panelists, Dr. Rajul, Dr. Murlidhar, Dr. Manoj, Dr. Rohit. We have a very nice discussion, at least some take-home message for a common ophthalmologist to because this is the hot topic in the media in every ophthalmologist domain in the last week, and we have taken this webinar at the very appropriate time. I am also thankful for the opportunity to connect with all of you, and I look forward for such webinars with AIOS so that we can learn and grow together. Thank you and good night.
Thank you. So I think I would like to personally thank Dr. Namrata ma'am for associating. Yes, I'm somebody who is part of both the teams under Dr. Namrata ma'am in the AIOS Scientific Committee, and also with Dr. Agarwal sir in MOS in Scientific Committee. So it is a great occasion for me to bring both my parent associations together. So, and it was good that I think this molecule has not been discussed at this scientific level ever in India. So I think anyone who has any question about this can definitely use this as a great resource, because everything which was discussed was completely scientific, unbiased, evidence-based, and great insights from everybody.
And I forget to thank my treasurer and our team, Dr. Aditi also. They are with us and giving their insights. Thank you.
Thank you.
We are thankful, Dr. Vardhaman and Santosh sir, for right time you have come out with this seminar. This is the right time. It was properly. Everyone in the market, in the society, as well as in the ophthalmic forum was in the need of exact guidelines, our guidance about the scientific guidance, and that is hitting at the right time. And that's why we are very thankful to the MOS and the AIOS Scientific Committee for bringing such an discussion, a thorough scientific discussion.
And the main instrumental is Dr. Vardhaman actually, and Dr. Namrata ma'am has consented for that we have made it pan-India. Thank you very much, ma'am. And Vardhaman also.
I actually wanted to do on presbyopia solution, then I talked to him and he said, no, he wants to do only on topical pilocarpine. So
yeah.
I think now this will be a great resource for people because a lot of things which Sabyasachi has shared, they don't have access to that in a easy understanding. So I think.
And correct interpretation of the way he's interpreted. I mean, it's not easy. If we study the topic, we'll study it differently. But the way he interpreted it in the most scientific manner, I think.
Very true.
Just, madam, I want to sir has said that we should not give guidelines. So what is your take on that? And as a AIOS or MOS, what we should go ahead? Means we should give the guidelines to our people or something like that. What should be our stand?
Through this webinar, we have given the message that pilocarpine, what should be the status of pilocarpine, where you can use it and where you should not use it. So as of now, I think there is no drug available because the current drug has been withdrawn. But as and when the drug becomes available or otherwise also, the message can go that where it can be used and where it cannot be used, some kind of a gist can be prepared. And I think that is, and it is coming all from the science and the medicine. Our webinar itself is a guideline.
Okay, that's true.
Yes.
Thank you, ma'am.
Thank you, everybody.
Thank you, everyone. And
Thank you.
yeah, thanks.
Thank you.